Hello class, hello professor. My name is Lynette Mahmoudi. Today I'm going to talk about the patient that came to our clinic on Tuesday. He was a 41-year-old Latino male, EG, his initials. He came into the clinic with his sister. They are both reliable historians. Why did I choose this patient? And it was very meaningful for me to choose this patient because I felt for it. I was just, it's not just as a doctor and as a person. This patient was not much aware of his disease. He was not even know why these things were happening to him. He came to the clinic because his sister asked for it. Another thing was, caught my attention. This patient haven't had any health insurance for the last 6 years, and he hasn't been seen a medical attention for the last 6 years. That's what he haven't had any idea about his physical or health condition. EG was 41-year-old Hispanic male. He came to the clinic with a company of his sister. They were both reliable historian. His chief of complaint was, I've been feeling tired and thirsty all the time. Excessive thirst, urination, and fatigue started about 3 months ago. And he also reported unintentional weight loss for the last 2 months. He denies any discomfort or pain. Discomfort, it was just a consistent use of bathroom. EG had no past medical history. His last physical exam, unfortunately, was 6 years ago. His last dental and vision check was about 10 years ago. He never had complaint of pain and hasn't visited any emergency room. He had no history of hospitalization or surgeries. He had no medication, environmental or latex allergies. He's not taking any medication. According to him, his childhood vaccinations were up to date, but he declined flu vaccine last season or seasons before, and he hasn't been even vaccinated for the COVID. His social history, he's a single man, moved to United States 13 years ago with his family. He works as a technician in a mechanic shop. He denies smoking cigarette or any illegal drugs, but he drinks 1 to 3 beers during the weekend. He doesn't exercise, another issue, since he comes home, he late from work and he feels very tired after work. He doesn't follow any particular diet. He eats Mexican food most of the time, and he drinks sodas almost every day. He's not sexually active and hasn't been sexually active for the last 2 years. He wears seatbelts when he's driving or he's in a passenger seat. He does not carry any weapons or guns. They just install a ring bell on their house as a security system. And he does not have any medication or medication cabinet. EG lives in a single family home. That's family history. He lives in a single family home with his parents and younger sister. His sister, she's 35 years old and has a history of hypothyroidism. His mother is 59-year-old and history of hypertension and obesity. His father is 76 years old and history of hypertension. His maternal grandmother is 79-year-old, had history of colon cancer and hypertension. His paternal grandmother is 80 years old and she has no past medical history. His paternal grandfather is 84-year-old and has a history of diabetes and kidney failure. The review of system, he admits that he's been fatigued, unattended red lights, and he denies any fever and chills. His eyes, cardiovascular, respiratory, and musculoskeletal, even neurosystem, he had no complaints. Renal, urinary, he admits to excessive urination, denies any hematuria or pain during urination. For the GI system, he denies any GI issue. Endocrine, he admits to polyuria, polydipsia, and denies any excessive sweating. Vital signs of his BP was little elevated. He was 138/86. The rest of his vital signs were between normal range. But we check AccuCheck or blood sugar check for him. It was 314 for his blood sugar for that day. Physical examination that performed, everything was between normal range, unremarkable. No vision change, no cardiac issue, no muscular skeleton issue, no neuro change. The labs that I ordered for that day for him, it was a fasting plasma glucose, A1C, lipid panel, CMP, and urine analysis. No other diagnostic testing was at the moment. My first choice of diagnosis was a type 2 diabetes. The differentials that I have for him was a type 1 diabetes, secondary diabetes, and diabetes insipidus, which I use up to date for my diagnosis. And I used 5 minutes clinical consult, but not really much, but mainly up to date. For the diagnosis for this patient. My primary diagnosis for him, it's type 2 diabetes due to the given age, his family history, and symptoms that he appears with. The type 1 diagnosis is less likely, but consider with the weight loss and symptoms that he has, that's why more diagnostic testing was required. Secondary diabetes can be used by use of medication like a steroid, pancreatic disease, or other endocrine condition, which we still rely on that pending due to the testing, but he's not taking any type of medication. Diabetic insipidus, it's also another, the polyuria and polydipsia is part of it, but typically without hyperglycemia, which we had a blood sugar of 314 for this patient. For diagnostic testing, the plan that we have for this patient confirmed with the repeat fasting glucose. Order baseline urine albumin and creatinine, consider C-peptide or autoantibodies if the type 1 diabetes is suspected for him. At the moment, the medication that I initial for this patient was a 500 milligram BID metformin, and titrate as tolerated, and then consider ACE inhibitor because of his blood pressure. The next option that I had, according to up to date, I was going to start the Lantus long-acting 10 to 20 units sub-Q every night to prevent any hypoglycemia for this patient. Also, but I hold on it till I get the A1C results for the patient. Education for the diabetic patients, there is so many educations. There is a education about the disease process, the disease that can affect their vision, to their kidneys, the neuropathy issues that can come with this disease, the combination, the diet, the diet process of this disease, lifestyle, the holistic approach that this disease have, that they have to incorporate diet, exercise, you have to use any available resources they have. We have to involve patient-centered approaches, that community helps that are available for this type of patients. We should mention it for this patient. He needs to learn about the monitoring his blood pressure, blood sugar, blood pressure, every routine follow-up, since now he has insurance. Also follow-up appointments that for him, we put it as in 4 weeks, but I will call him to let him know the result of the blood work. Ophthalmology follow-up is one of the important things for any retinopathy screening that can happen for this patient. Also, they need to do nephrologists and endocrinologists follow-up if we cannot control his blood sugar by supporting medication, and we have. For Jane Watson's, I think for this patient, we need to promote of teaching and learning. Basically, teach him what he needs to do for his disease and disease process. And he's not just listening. We have to they have to show us what learned and what they done for their disease. Basically, that's one of the most important aspect of it. Sometimes you feel the patient is listening, they're listening, but when they go home, they just do different things. Like, for example, the approach that I had for him, that probably I will add a Lantus for him, he was like little iffy if he wants to get insulin shot. Insulin for him was like little something different. Or I told him, oh, you need to check your blood sugar, you need to just log your blood sugar and everything. Even I was asking him to log his blood pressure too, since they have the family history of hypertension. He was like not really into it with him, but I had to explain it. I had to let him know the outcome of this disease if it doesn't follow up properly, or it doesn't really taking care of it. Or he says, is these medications are like a temporarily, or I have to take this medication for a lifetime. Those are the things that it was really, that's why another John Watson idea comes in, the promotion and acceptance of the expression, positive and negative feelings of the patients. Basically, what do they feel about their disease? How do they approach? How do they absorb? This is one of the important things I feel about this patient. I am going to have a follow-up appointment with him, and I want to really, it's one of those patients that touched me in person, and I wanted to be having a very close monitor to make sure he understands, he follows, and to have a better outcome for his future. He's only 41. Thank you for everything. Thank you.